Hi, Louisa. Can you hear and see me okay? And let me share my screen. Can you see that as well? To the beginning. Did anyone in the meeting just confirm that they can see the slides okay? And you can see them advancing?
Yep, I can see them okay. And we can
Fantastic.
see them advancing as well.
Perfect. Thank you very much. Thank you. Hey everyone, we can get started shortly. As you can see from the title today, there's an awful lot of content to get through, so I'm going to whiz through it quite quickly. If you have questions at any point, I'm happy to either take them as we go along or either take them at email afterwards or at the end, depending on what's most convenient for you. And obviously, if you the feedback form at the end will take you to there's a QR code which will take you to a feedback form which will give you access to the slides for today, so you can hopefully go through them at a slightly slower pace if there's anything that wasn't clear at the time. So what time are we on? 7. So let's get started. So my name's Aaron. I'm a PhD student in cardiovascular science, and I matriculated in 2019, and I'm intercalating this PhD between years 3 and 4 of the medicine course. So I've been in your position a few years ago now. So, as I said, today we're going to be thinking about posture, exercise, altitude, and temperature. And what do they all have in common? Well, they all present fundamental threats to homeostasis. This was a concept which emerged in the early 20th century with people like Bernard and Walter Cannon. And essentially, it's this idea that there's a threat, there's a change in the environment, the external environment, and this is sensed by receptors, which is then integrated. These signals are integrated. This error signal is integrated by some kind of control center, and then an appropriate response is mounted to counteract that change. So all of them, so everything we talk about today, I want you to consider in this context of homeostasis and the kind of responses that must be mounted to maintain a constancy of the internal environment. So the first thing we're going to talk about is change in posture. This is your syllabus. Throughout, I've basically annotated the slides with these traffic lights. So green is stuff that's on the left-hand side of the syllabus, and then clinical stuff in yellow, and then experimental stuff, which you might want to mention in essays in red. So the orthostatic challenge then, what is the orthostatic challenge? It's essentially the challenge to the cardiovascular system upon standing, driven by a redistribution of blood, particularly below the diaphragm. The thoracic blood moves to below the diaphragm and particularly into the GI tract and into the legs. This leads to a reduction in the venous return by 2 mechanisms. One, because there's simply less blood returning to the heart because it's now in the lower half of the body, but also due to a decrease in circulating plasma volume. What causes this? Well, this is driven by an increased filtration in the dependent vasculature. So in the lower limbs, you've got a redistribution of the Starling forces. If you've got more blood volume within those capillaries in the lower half of the body, this is going to increase the hydrostatic pressure gradient to drive extravasation of fluid and therefore a reduction in the plasma volume. This reduction in venous return, therefore, leads to a reduction in stroke volume, as the Frank-Starling relationship will tell you, and therefore a reduction in cardiac output. There's also changes in the dural sinus drainage within the brain, and this is, again, due to subatmospheric pressure experienced in the brain, and this can be seen on MRI. And it's important to note at this point that in healthy people, compensatory responses should be adequate so that you don't end up hypotensive, or at least if you do, it's very quickly rectified. So that's the threat, that's the change. If you think about homeostasis as that model, that's the stimulus. What's the response? Cardiovascularly, you've got a homeostatic response mounted by the detection of the drop in blood pressure by the arterial baroreceptors. These are in the carotid sinus principally and in the aortic arch. These are detecting transmural pressures, so high arterial pressures, and cardiopulmonary baroreceptors as well. These are experiencing lower pressures and are located in the atria, in the ventricles as well as in the pulmonary vasculature. And what these do is they detect that reduction in blood pressure, they increase sympathetic outflow, leading to an increase in heart rate and vasoconstriction, particularly in the splanchnic vasculature. So this is the GI tract, the liver, etc., which leads to basically an increase in venous return and an increase in cardiac output via that increase in heart rate. And also humoral activation of, for example, the renin-angiotensin-aldosterone axis. And it's important to note as well that physical activity can help counteract some of these challenges upon standing, because as we exercise, the skeletal muscle pump is activated. This also helps boost venous return, as does breathing, because we know that breathing is associated with pressure changes within the thorax, which can help draw blood back into the thorax and ultimately back into the heart. I just want to point out this graph here on the right. This was data from a longitudinal study which looked at over 4,000 participants, and you can see that you can see that in the initial response upon standing, so this is an active stand test, there's a reduction in systolic and diastolic pressure. This is mitigated to some extent by an increase in heart rate. And importantly here, just as an interesting aside, in that the heart rate response, or the restoration of heart rate in the 10 to 20 seconds following standing, was a predictor of long-term mortality. So these are autonomic function, and this is a good way to assess autonomic activity and is a predictor of long-term outcomes as well. And we'll come on to that more in a moment. This is just a reminder of the baroreceptor reflex. So again, you've got your arterial baroreceptors located in the aortic arch, as well as the carotid sinuses. Remember, the ones from the aortic arch are coming from cranial nerve 10, the vagus nerve. The carotid sinus are being, the afferent signals are being transmitted by cranial nerve 9, or the glossopharyngeal nerve. And these are sent to what we call the nucleus tractus solitarius, or the NTS, within the brainstem. This would ordinarily, tonically, or basally inhibit output from the ventral lateral medulla, VLM. So this is a diagram I've taken from one of my essays. If we have a reduction in blood pressure, there's reduced afferent input into the NTS, and the NTS would normally inhibit the ventral lateral medulla, which would be providing sympathetic output. So if we decrease our input into the NTS, this results in disinhibition of the ventral lateral medulla, and therefore increased sympathetic output to increase heart rate, vasoconstriction, positively inotropic as well. So orthostatic hypertension then is a pathological phenomenon and arises when your autonomic response is insufficient. It's defined as a reduction in blood pressure, so this is systolic drop of greater than 20 millimeters mercury, or a diastolic drop of less than 10 within 3 minutes of standing. We know that age is a major risk factor, affecting approximately 20% of adults over the age of 60. Clinically, it presents as lightheadedness or dizziness, which is resolved upon lying, cognitive slowing, people talk about being cloudy, dizziness, etc. Particularly in the elderly, unexplained falls or syncope as well. And as I said, its cause is primarily an insufficient autonomic nervous system response. This can be neurogenic or non-neurogenic in origin. If it's neurogenic, it's characterized by a lower heart rate when you stand up, because if you've not got the right sympathetic input, your heart rate response is going to be inadequate. Non-neurogenic causes include fluid depletion. So if you've already got a reduced fluid volume, if more of it pulls below the diaphragm upon standing, this is going to lead to an even a greater drop in venous return and therefore cardiac output. The heart can only output what is presented to it in the form of venous return, or it can be drug induced. For example, beta blockers, if you're going to pharmacologically inhibit your sympathetic system, that can lead to orthostatic hypertension. Prognosis is that it increases risk of other adverse cardiovascular outcomes, particularly atrial fibrillation, heart failure, coronary artery disease, venothrombotic events or venothrombotic embolisms, and ultimately increased all-cause mortality. So treatment then, so if it's been caused by drugs, review the medication, avoid triggering situations, so stand up more slowly, stand up in stages. If it's fluid depletion, increase water or salt intake to increase the effective circulating volume. Compression stockings can help with boosting venous return. Physical conditioning, remember the skeletal pump is an important stimulator of venous return upon standing, as well as in serious circumstances, pharmacological options, for example, alpha agonists such as midodrine. So this is on the right-hand side of the syllabus, but it talks about a link between orthostatic hypertension and diabetes, particularly type 2 diabetes. And what causes this is ultimately the association is explained by the common factor of autonomic failure. So in long-standing diabetes, there's a reduced total vascular resistance and an autonomic neuropathy due to damage to the efferent sympathetic vasomotor fibers and afferent fibers by basically high levels of glucose in the blood. It leads to advanced glycation end products, which can lead to increased oxidative stress. If you want to go into the sort of molecular mechanisms of how hyperglycemia leads to neuropathy, there's an interesting review that I highlight on the right-hand side of the screen. And this is present in up to 1/3 of type 2 diabetics. And again, autonomic dysfunction is at the heart of this connection, sorry. This study then, if you want to mention it in an essay perhaps, cardiovascular autonomic neuropathy is not benign. This summarizes 15 studies that looked at follow-up mortality and found that in the presence of one or more abnormal autonomic function tests, so there was 5 different ones. The details don't really matter at this stage, but essentially related to heart rate variability, blood pressure changes in certain situations. We can see that the presence of these features of autonomic neuropathy was associated with a 2.14 increased risk of fold increased risk of basically death, mortality. So it's certainly not benign and can pose quite a threat. So that's the first challenge. The next challenge I want to talk about is exercise. So these are some past paper questions on exercise. In my experience, orthostatic hypertension or the challenges of orthostasis is probably not big enough on the syllabus to be an entire essay, although I say that it might come up, or it might have come up last year. I'm not entirely sure. But exercise is definitely one that comes up relatively frequently. So just to introduce exercise, the threat in the context of exercise to homeostasis is ultimately the need to maintain adequate respiratory substrate delivery and remove toxic metabolites from the respiring muscles. So we need to deliver more oxygen to the muscles, and we need to get rid of lactate, CO2, etc. So exercise is defined as the voluntary exertion of skeletal muscle, and as I said, poses challenges to both the cardiovascular, the respiratory, and the skeletal systems. And I'm going to go through each of those in turn, particularly the cardiovascular and respiratory systems. We know that in exercise, our work increases. This increases energy consumption, ultimately meaning we need more oxygen delivery. And our oxygen demand, or our VO2, our oxygen consumption, can increase up to 12-fold. So from a basal rate of about 250 mils per minute of oxygen to 3,000 milliliters per minute. So this is quite a substantial challenge to both the lungs that need to take the oxygen from the air and the cardiovascular system, which then needs to deliver it to our muscles. And I'm going to consider both acute and chronic responses to exercise in the following slides. So just as a reminder, you'll remember this equation from your first year lectures, the equation for total body oxygen consumption. So this is the product of cardiac output, the hemoglobin concentration within the blood, and then what we call the arterial venous difference. So this is the saturation in the arterial system, subtract the the saturation of oxygen in the venous blood. So if we look at these variables, the only things we can change in an acute setting is the venous saturation of blood. And the reason I say this, and the cardiac output, sorry. The reason I say this is because we can't change the hemoglobin concentration acutely. We need to translate more hemoglobin. That's not something we can do in seconds. And we already operate, even at rest, at basically nearly 100% oxygen saturation within the arterial blood. So what we can do in exercise is we can increase the arterial venous difference by 3-fold. So the venous saturation will move from 75% down to 25%. Again, this is maximal. This is when you need a full 12-fold increase, as well as an increase in cardiac output by about 4%. So focusing first on cardiac output, the first term, cardiac output increases proportionally to oxygen consumption, predominantly driven by an increase in heart rate, because we know that if you were to plot the stroke volume as a variable against your VO2 or your oxygen consumption, your stroke volume plateaus at about 1/3 of your maximum possible oxygen consumption for any individual. And what increases the heart rate then? You get basically a lifting of the brakes. So that's the reduction in vagal tone at both the sinoatrial node and the atrioventricular node, and then you get an increase in the sympathetic drive. So an increase on the accelerator on the heart, and this is supplied to the heart by the superior, middle, and inferior cardiac nerves. And then if we think about this second part, the increase in arterial venous difference, this is due to, so we need to drop this term, the venous saturation. This happens due to reduced oxygen tension in myocytes. So more oxygen is sucked out of the blood. So what leaves the muscles is going to have less oxygen. There's also the Bohr effect. So remember, this is a right shift in the oxygen dissociation curve, and this is driven by an increase in the local carbon dioxide concentration. We also have metabolic hyperemia. Hyperemia just means high blood flow. Emia, blood flow, hyper high. This is driven by metabolic substrates, for example, protons, potassium, for example, adenosine. This increases blood flow locally, helps deliver more blood to the respiring muscles. And also we recruit more capillaries. So not all your capillaries in the muscles are going to be receiving blood at rest. These can then open and more blood can travel into the muscles. So more blood can be taken out of the arterial system to increase that arterial venous difference. And the renal and splanchnic arteries constrict. So you're diverting blood away from going to the kidneys or to the GI tract, liver, etc., and redirecting it towards the muscles. There's also an overall drop in peripheral resistance. If you think about your ohmic relationship, if you decrease the resistance, you can deliver more current, or in the case of the cardiovascular system, more cardiac output without, for a given blood pressure, for a given drive or voltage or blood pressure in the case of the cardiovascular system. So we maintain a higher cardiac output at the same level of blood pressure. And chronically then, so these are all acute responses. Chronically, we can obviously increase our hemoglobin concentration, so affecting that term here. Okay, so slide's not wanting to advance. So this is just a diagram of that. 12-fold increase in oxygen delivery is mediated by a 3-fold increase in the arterial venous difference multiplied by a 4-fold increase in cardiac output. So a bit of experimental evidence here for you of the role of the sympathetic nervous system in mediating that cardiovascular response to exercise. So what Donald did here in the 60s was he denervated, so basically cut the sympathetic nerve supply to the hearts. And these dogs, these greyhounds, had an attenuated cardiovascular response, cardiovascular response measured as heart rate. So they had a reduction in their heart rate response to exercise when you cut off these nerves. And when they treated these dogs with propranolol, so this is a beta blocker, there was a further decrease. So the beta blocker dogs are in with the black circles versus just the denervated dogs in the white circles. And you can see that there's an almost completely abolished response to exercise in terms of the heart rate anyway. And what this experiment tells us is that both sympathetic innervation, so direct sympathetic innervation via the superior, middle, and inferior cardiac nerves, and an increase in the circulating catecholamines, probably driven by adrenal production of these hormones, increase the heart rate during exercise, such that the denervated dog is almost entirely reliant upon. Sorry, I don't know what to do. Can you still see the slides? They disappeared for a second for me. If you can't, just let me know in the chat, but if not, I'll continue. So in the denervated dogs, they're entirely reliant upon the circulating hormones to increase their heart rate. And this has clinical implications, for example, with patients that have had heart transplants, because in the context of heart transplant, these are essentially denervated patients. So they're entirely reliant on circulating catecholamines. So if you give these patients beta blockers, they are going to really struggle during exercise and experience exercise intolerance. So that was the cardiovascular response. Let's turn our attention then to the ventilatory response. So minute ventilation, as a reminder, is tidal volume and respiratory rate multiplied together. And we know that ventilation increases linearly with metabolic demand, as shown here. So metabolic demand on the x-axis measured as oxygen consumption, until we reach this break point, which is thought to consider with the anaerobic threshold, where ventilation becomes uncoupled from oxygen demand, and we have this exponential increase in ventilation, driven primarily by an increase in the respiratory rate as opposed to an increase in the tidal volume. In healthy individuals, it's important to note that it's not the ventilatory system that limits exercise. So we can deliver enough oxygen to the lungs. What's limiting us is the capacity of the cardiovascular system to deliver this oxygen to the respiring muscles. And chronically, with training, we can increase capillary density within the lungs, within the muscles, and we can increase our glycogen stores. So this means that we have more fuel available within the muscles, and we can also increase our heart size, cardiac hypertrophy, which can help us increase stroke volume and cardiac output. These are the kind of things that are going to improve our exercise capacity, because it's not necessarily the lungs unless there's some kind of underlying pulmonary pathology, for example, COPD. In that case, the ventilatory system will be the thing that's limiting exercise. So it's important to note that during exercise, the source of ATP, remember ATP is what's needed for cross-bridge cycling and muscle contraction. The sources of ATP change. If I set off sprinting now, I'm going to need ATP immediately for the muscles to contract and for my legs to move, but I've not had a chance to deliver more oxygen yet. So I can't rely on aerobic metabolism. So what I do initially is I break down existing pools of ATP present within the myocytes. Then that gives way to the breakdown of creatinine phosphate, which, remember, is a local source of phosphate. So ADP can be converted back to ATP. And then this will give way to anaerobic metabolism. So I'll break down glucose, which may be present in the form of glycogen within my muscles. And this is all before I've had a chance to get more oxygen to my muscles. Remember, anaerobic metabolism compared to aerobic metabolism is a very inefficient process, approximately 12 times fewer ATP molecules per each glucose molecule compared to aerobic metabolism. And it has the side effect of also leading to lactate accumulation, which we know is bad news. It affects pH and can also lead to pain. And then once we've got more oxygen delivery, this can give way to aerobic metabolism, which is, necessary for the long-term energy production. And initially, aerobic metabolism is fueled by carbohydrates. With prolonged exercise, this shifts towards lipids, which are more energy dense, so we can generate more ATP per gram, essentially, of fuel. And this is associated with change in the respiratory quotient, which, remember, is the CO2 production over the oxygen consumption. So those are the error signals. So we need to increase our cardiovascular and ventilatory response in the context of exercise. How is this matched? What are the error signals that tell our central centers that we need to basically breathe, or our heart needs to work harder? So thinking first about ventilation, there are a few different theories. For example, changes in pH or lactate sensed by chemoreceptors is proposed to be a major mechanism by which ventilation is matched to metabolic demand. Evidence for this comes from, for example, children with congenital central hypoventilation. They lack chemosensitivity during exercise, and they have impaired ventilatory responses after the anaerobic threshold, so they don't respond to the accumulation of lactate, etc., in the way normal people would. So they have a normal initial ventilatory response during the aerobic period. When it becomes anaerobic, their ventilation lags behind oxygen demand due to impaired chemoreceptor function. In submaximal exercise, however, if I was to measure your arterial oxygen or CO2, it wouldn't be hugely unchanged. If you went out for a gentle jog, your arterial oxygen partial pressure wouldn't significantly drop, which raises the question then, what is providing the error signal to the ventilatory centers to tell them that you need to breathe harder? Lots of different theories have been proposed here, and there's no consensus, but a few mechanisms which might be important. One was proposed by Band and colleagues in the 80s and involved arterial pH oscillations. So he proposed that even though the average arterial pH or arterial pH, CO2 concentration stayed the same, what happened was there was larger swings in it, probably due to the fact that you were breathing harder, and if the tidal volume is greater, you're going to take more CO2 out with each breath, but more is going to be put back in by the actively respiring muscles. And he suggested that maybe the peripheral chemoreceptors can sense this oscillation. They have a sufficiently high dynamic sensitivity to detect these larger oscillations, and it's that what led to the ventilatory response, perhaps particularly during phase 3. So remember, the ventilatory response is characterized into phases. You've got this initial phase, and then a gradual rise in ventilation, then it's sustained, and then after exercise, it begins to decrease. It's proposed that once you've got these large oscillations that are kind of rhythmic and consistent, that might be involved in the phase 3 response. You've also got muscle afferent feedback. So sensory neurons present in muscles themselves might be feeding back to tell the central centers that you need to be breathing harder. And evidence for this is that if you exercise and then you maintain the metabolites in the muscle, so if you stop exercising but apply a tourniquet so that all the toxic metabolites that have accumulated within the muscles are retained there and they're not washed away, you have a sustained ventilatory response. So what that indicates is that some of these factors generated in the muscles are being sensed locally, and this is driving the ventilatory response. And there's a similar thing for cardiovascular function, which I'll talk about in a second. And also those are both feedback mechanisms. So once we have an error signal, how do we then mount the response? What is the error signal, and how is that leading to a response? But there's also what we call feed forward control. So this is basically an anticipation of exercise. So this was first thought of by Crowe and Lindard in the early 20th century. And this might be important, particularly in phase one. So at the onset of exercise, before you've had time to accumulate all these toxic metabolites, what's driving that immediate increase in ventilation? And it's maybe thought of as feed forward central command. So basically higher centers in the brain, preparing you for exercising and increasing your ventilation in the absence of an error signal. So cardiovascular function, how is that then matched to metabolic demand in the context of exercise? Again, there's ideas of feed-forward control. Johansson proposed these in the 19th century. And evidence for this comes from Gandevia et al. In the 90s, which found that if subjects were paralyzed, so using neuromuscular blockers, so very brave participants, but told to think about exercising or told to exercise essentially, but obviously physically they weren't exercising. So there wasn't an actual increase in metabolic demand. Their heart rate and their blood pressure increased proportional to the graded mental effort. So if they were told to exercise moderately, vigorously, their heart rate and blood pressure response would increase proportionally to what they were thought they were doing, even though, of course, there wasn't actually an increase in metabolic demand. So this raises the idea that there might be feed-forward control in that you don't need an error signal actually to increase your heart rate and blood pressure. And then feedback mechanisms. Again, we've got stretch-sensitive mechanoreceptors in the muscles, which can inhibit vagal tone. And, if we inhibit vagal tone, this leads to an increase in heart rate. And also, as exercise progresses, this leads to the accumulation of metabolites locally, for example, potassium, adenosine, which can stimulate your metaboreceptors. And again, similar to the ventilation, if you apply a pneumatic cuff, so basically stop the washing out of these metabolites after stopping exercise, this can prolong the muscle pressure response, so the increase in blood pressure. And interestingly, they found that didn't affect ventilation. So you could perhaps compare this study, albeit from the 1930s, to the more recent study on the previous slide, which found that it did affect ventilation. And you can maybe think about why that difference might be. And this metaboreceptor-driven response is thought to be particularly important in the context of isometric contraction. So when you're approaching the anaerobic threshold, and this is just a diagram showing how some of these receptors might be involved and how they might then be integrated in the medulla. You might be getting feed-forward control from higher centers, and then some of the effects, so decreased parasympathetic, increased sympathetic, leading to increased cardiac output and increased vasoconstriction in your other organs that are not requiring increased blood flow, for example, the GI tract. So another interesting experiment I just want to highlight, I'm just going to focus on the second part of this paper. So this was a really brutal experiment done in the 60s by Cowan colleagues. And what they did, well, they did a few things, but this experiment I want to highlight, I think, was the final one. If we focus on this dog in the middle, this was the neural dog. So what they did in this dog is they stimulated its muscles electrically, and they found and they perfused its central chemoreceptors with blood from a dog that wasn't exercising. So it wasn't receiving any kind of humoral factors, but they took the blood that was being drained from the exercising muscles and put it into this other dog, termed the humoral dog, because it was receiving all of the humoral factors from respiring muscles. And what they found is in the isocapnic neural dog. So this dog is again being perfused with blood from a non-exercising dog via its central chemoreceptors. So it's not got an error signal there. Its ventilation and its ventilatory response increased, suggesting that direct afferent feedback from the exercising muscles alone was enough to increase ventilation in the absence of changes in the systemic or the factors experienced or the error signal experienced at the central chemoreceptors. In the humoral dog, so this dog isn't exercising, there's no feedback from the muscles. All it's receiving is changes in the systemic composition of the blood. So it's getting all the CO2, the lactate, etc., from the muscles. So presumably the central chemoreceptors are detecting this. This dog's ventilation increases. The conclusion, therefore, being that both neural, so factors originating directly from the exercising muscle, and humoral factors, so spillover of metabolites into the blood, which might be detected centrally, both of these responses contribute to the ventilatory response. And indeed that neither factor alone can account for the entire response. And I think in this lies the answer as to why it's so difficult for me to tell you what increases ventilation in the context of exercise. This is absolutely fundamental, right? We have to be able to match our ventilation to our metabolic demand. So it's not at all surprising that perhaps there's redundancy in the system, there's synergistic mechanisms that if you experimentally perturb a single facet of this regulatory axis, you won't completely abolish the response. So all these experiments or papers where they've maybe just blocked neural factors or just blocked humoral factors and still see a ventilatory response is perhaps because other mechanisms can just compensate for that because of the importance of this phenomenon. And I think, I think that's a point I made in some of my essays, that it was, there's such redundancy in the system. It's not surprising that there's great redundancy in this system. Evidence for the role of central command then in the cardiorespiratory response. So what this is isometric contraction. So this participant is being told to basically maintain a steady load, basically pulling down on this weight. Triceps muscle is holding this weight there. And if they basically vibrate the biceps tendon so that the brain, the stretch response is activated, the brain thinks that there's more load, even though there isn't actually more load. The work being done remains constant. There's nothing changing to the weight, just the brain thinks there's more because you're stimulating the biceps, that's activating the stretch receptors, etc. This leads again to an increased central command because the brain thinks there's more load, even though again, there's no more error signal, there isn't any more load. And this leads to an increased cardiorespiratory response. So highlighting the role of muscle afferent fibers in matching cardiorespiratory function to muscle demand. So just a bit of pathology in the context of exercise. Any impairments to respiratory or cardiovascular function are going to impair exercise capacity. Coronary artery disease, for example, presents as angina pectoris or chest pain. This initially, in the early stages of coronary artery disease happens particularly on exertion, because that's when you're throttling the heart, when the oxygen demand of the heart is increasing, and that's when you start to notice symptoms. It's severe stages of disease, of coronary artery disease. You can experience pain at rest. And respiratory function, if you have impaired respiratory function, for example, left ventricular failure, COPD, asthma, all of this can lead to shortness of breath on exertion. And of course, there are those funky genetic diseases that you'll remember from first year. For example, McArdle's disease, characterized by myophosphorylase mutations. This impairs the muscle's ability to mobilize glycogen reserves in the context of exercise and leads to premature fatiguing. Okay, so let's move on to our next threat to homeostasis, high altitude. So Oxford loves altitude, and this kind of reflects itself in the fact that there's lots of questions on it, both in first and second year and third year as well, if you do that module. So what are the challenges of altitude? And I'm going to define altitude as ascent to more than 2,500 meters above sea level. There are several challenges. There's the fall in temperature, there's the low humidity, there's UV radiation due to changes in the atmosphere composition. This leads to mutagenic effects. There's obviously remoteness. This poses challenges for healthcare provision should you fall ill. But ultimately, the one we're going to spend most of our time thinking about is hypobaric hypoxia. And that's basically the reduction in arterial oxygen content arising as a response to the reduction in barometric pressure. So hypobaria, which we know is associated with altitude. The further we go up, the further barometric pressure falls. The reason, I guess, well, at least our lecturers will tell us that altitude is really important is because it serves as a model for hypoxia. And we know hypoxia physiology is important for many different diseases, for example, COPD, COVID, pneumonia, heart failure, etc., shock. And I'm going to speak a lot about acclimatization as well. So this is just to define acclimatization at this stage, and that's the time-dependent physiological adaptations that occur on ascent to altitude, and they encompass changes to all of the different systems, well, not all of the systems, but many of the different systems in the body. For example, the respiratory, the hematopoietic, as well as the cardiovascular system. And ultimately, these changes serve the purpose of maintaining arterial oxygen content, or at least trying to prevent the fall as much as possible. So you probably are sick of seeing this equation by now, but this is the alveolar gas equation. And reminder that the alveolar gas equation is a way to estimate the partial pressure of oxygen within the alveolar gas. We cannot measure this directly, or we can't do this easily. So we basically take things that we can measure, substitute this into an equation, and this gives us an estimate of the partial pressure of oxygen in the alveolar gas. So let's think what happens to this equation at altitude. At altitude, the fraction of inspired oxygen doesn't change. It's still 21%, but what does change is the atmospheric pressure. Atmospheric pressure drops, as I said, proportional to the extent of the altitude. So if that falls, what we can do, if we look at this equation, the only other thing we can change, we can't change the relative, the partial pressure of water within the air, or the degree of humidification. The body can't change that anyway. The respiratory quotient is kind of determined by the fuel consumption, not easy to change acutely. What we can do is we can drop the arterial content, or the arterial partial pressure of CO2. The way we do this is we increase our ventilation. And just a reminder that the arterial content of CO2 is inversely proportional to ventilation. So if we increase ventilation, we can boost our arterial or our alveolar oxygen content. So you might be familiar with the oxygen cascade. You might have seen this in a lecture. This is just a plot of the partial pressure of oxygen at various different stages as oxygen, first of all, is in the air, then it goes into our lungs, then it goes to the alveoli, then it goes into the arterial blood, and then finally into the mixed venous blood. What we can see in the context of altitude is that there is a drop in the AA gradient, so between the alveolar gas and the arterial blood. And remember, it's the AA gradient, or the alveolar arterial gradient, which is essentially the pressure or the force which is pushing blood from the alveolar gas into the lungs. That's driving that diffusion of oxygen. So at altitude, we're essentially in a situation of diffusion limitation, and this is due to that reduced pressure gradient between the alveolar gas and the arterial blood. And remember, because we're dropping in the arterial oxygen content, this is happening on the steep curve of the oxygen dissociation curve. So even a very small drop in alveolar PO2 is going to lead to quite a substantial drop in arterial oxygen content, because we're on that steep fall, we're on the steep slope, sorry, of the oxygen dissociation curve. And this also explains then why exercise or exertion worsens the AA gradient, because if you start exercising, you're going to increase your cardiac output, as we discussed in the previous section. And what this does is it gives the erythrocytes, which are traveling through the pulmonary vasculature, are having to move more quickly. So they've got less time to equilibrate their oxygen content with the alveolar oxygen content. So the hypoxic ventilatory response helps minimize this fall. So the hypoxic ventilatory response is basically an increase in ventilation in response to hypoxemia. So if we look then at the ventilatory response in response to hypoxia or altitude, what we can see is there's initially this increase in ventilation, followed by a drop in ventilation, followed by this time-dependent increase in ventilation known as acclimatization. So initially, ventilation is increased, by the hypoxemia. Remember, our peripheral chemoreceptors located in the glomus, close in the carotid body, the glomus cells in the carotid body, sense this drop in arterial oxygen. They project to the central centers. The central centers increase ventilation. Subsequently, though, if you increase ventilation, as we've said, what that does is it drops arterial content of CO2. Now, your central chemoreceptors don't like this because you're now alkalotic. The central chemoreceptors are thinking, right, we need to decrease ventilation to prevent this respiratory alkalosis. And then what happens, obviously, we don't want to be decreasing ventilation because that's going to lead to arterial hypoxemia. And, that, as we've discussed, is problematic for many reasons. But luckily, over the next sort of hours and days, what we get is acclimatization, which sustains an approximate 5-fold increase in ventilation, along with other changes, which I'll mention in the next few slides, which can help ultimately sustain arterial oxygen content and delivery of oxygen to the muscles that need it. So what are the mechanisms of ventilatory acclimatization? I'm going to discuss a few mechanisms, but I want to just point out that in an essay, you should be really talking about the textbook view. And then I'm going to give you some other interesting possibilities. But your lectures and textbooks will tell you that it is the loss of renal bicarbonate which helps restore pH. So remember, if we, in that initial hyperventilatory period, in that initial response, that's going to make us alkalotic. So to respond to this, the kidneys excrete bicarbonate to help restore pH, which is then sensed by the central chemoreceptors and then leads to an increase. Then our ventilatory response can be increased because we've still got that hypoxic error signal. What we don't have anymore is the central chemoreceptors experiencing alkalosis. Evidence for the importance of this effect is derived from several different lines of inquiry. For example, the Caldwell x Everest participants, what they did in that study is they measured serum bicarbonate, and they found that it was as low as 10.8 millimolars. Remember, from first year, that bicarbonate should be around 24 millimolars. Earlier evidence measured the CSF content of bicarbonate. Remember that the CSF is the thing that's more relevant for the central chemoreceptors, and they found that it fell, in that period, and they sampled it using lumbar puncture. And also evidence, perhaps more indirectly, is that acetazolamide, which is a carbonic anhydrase inhibitor, so this will increase renal loss of bicarbonate. This is shown to be an effective prophylaxis in the treatment of acute mountain sickness, so further indicating that it might help with those beneficial ventilatory responses, those acclimatization responses. And this graph you might have seen as well from your lectures. I've just recreated it here. Central chemoreceptor sensitivity can be displayed essentially as a fan of these ventilatory PaCO2 curves. So what that means is that the ventilatory response to changes in CO2 is much more sensitive in the context of hypoxia. So when we have normal arterial content of oxygen, we've got a quite shallow response. So basically, we need to get a lot of CO2 before we're going to be massively increasing our ventilation. We're much more tolerant to hypercapnia in the context of normoxia. In the context of hypoxia, we're much less equipped to respond to hypercapnia. So we can see that very small increases in CO2 here drive very large increases in ventilation. So in hypoxia, we tolerate hypercapnia less well. And that you can see how that might then lead to acclimatization or might help sustain that acclimatization effect. Now, I said that I was going to mention some other mechanisms of acclimatization. Again, the main one that you should be speaking about in your essays is renal bicarbonate loss. However, there are other theories. So a few of these theories kind of converge on this idea of plasticity, both at the level of peripheral and central receptors. And this is based on the idea that there's some data that suggests that alkalosis experienced either in the blood or in the CSF is never actually corrected. So the error signal being experienced by the central chemoreceptors is never actually changing. So what changes? Why does ventilation then start to increase? Why does it not continue to be suppressed by the central chemoreceptors experiencing alkalosis? Well, a few different explanations here. Bush in the 1980s found that if he perfused goat carotid bodies, so the peripheral chemoreceptors, with the same level of hypoxia with normocapnic blood, independently from the systemic arterial system, so they kept the systemic system normoxic, this led to an acclimatization response. And this suggests that systemic hypoxia is not required for the ventilator acclimatization, and that the carotid bodies alone can drive acclimatization. But what's interesting here is that the degree of hypoxia experienced at the levels of the carotid body was constant. It didn't change. It wasn't as though, you know, it was changing. So the error experienced by the carotid bodies was constant, which suggests that the sensitivity of the carotid bodies, so you can imagine this as if you measured the afferent output of the carotid bodies, say you recorded the action potentials in the nerves that were coming away from the carotid bodies, the degree of firing would change for a given hypoxic stimulus, so a given level of hypoxia. So perhaps over time, as we're experiencing altitude, the output from the carotid bodies increases for the same level of hypoxia, which drives more ventilation. And maybe that's responsible for the acclimatization. Now, how may they be responding, or what might the molecular mechanisms of this change in sensitivity be? Well, HIFs, as you won't be surprised to hear, have been implicated. We know how important they are for the kind of cellular changes in the context of hypoxia. So HIFs, as a reminder, are constitutively degraded in the context of normoxia, but we know that in hypoxia they are stabilized, leading to, and these are transcription factors, which leads to the transcription of genes such as erythropoietin, VEGF, which is a driver of neovascularization, as well as endothelin-1. And if we look at mice that have loss of function of HIF-1 alpha, so reduction in this axis, they have a depressed neural response to hypoxia and abnormal acclimatization, which suggests that HIF-1 alpha may play a role in acclimatization, perhaps by altering peripheral chemoreceptor sensitivity, suggesting that acclimatization is driven by hypoxia rather than the change in the error signal experienced by the central chemoreceptors, which the textbook would tell you is due to the loss of bicarbonate at the level of the kidneys. So pathology at altitude then, high altitude pulmonary edema is one of the major pathologies you'll encounter in your lectures. And this is driven by the phenomenon of hypoxic pulmonary vasoconstriction, HPV. What drives HPV is not entirely clear. However, it's been proposed that it might be due to mitochondrial products, and the evidence for this is that if you inhibit the electron transport chain, you can attenuate the vasoconstriction in response to hypoxia. At sea level, HPV is useful to us. It helps with VQ matching. For example, if we have an area of the lungs which is not being well ventilated, we can turn off the perfusion to that area by constricting those vessels. So we ensure that we're not delivering blood to areas which are not having any oxygen. Altitude, it doesn't serve a useful purpose. We end up with patchy vasoconstriction, which leads to relative hyperperfusion of some capillaries and stress failure, which can lead to edema due to the fluid extravasation, which can present itself clinically as coughing, difficulty in breathing, and reduced exercise capacity. So how can we adapt chronically to altitude? We know that on progressive ascent, there's initially, so at moderate altitude, there's a right shift in the dissociation curve. So this reduces the affinity of hemoglobin for oxygen, which favors the offloading of oxygen in our tissues. As we move up in altitude, the hypoxia worsens. This left shifts the dissociation curve, which helps uptake oxygen at the lungs. That right shift that I mentioned before it's thought to be driven by end capillary acidification, as well as the 2,3-DPG, which we know modulates hemoglobin activity. There's also increased vascularization of the tissues driven by VEGF, which, as I said, is transcribed following activation of HIF or translocation of HIF to the nucleus. You've also got a polycythemic response, increased hemoglobin. This was reported by Mabel Fitzgerald in the early 20th century, as well as EPO production by the kidneys. Obviously, she didn't know EPO about erythropoietin or HIF, etc. at that time, but it's subsequently been elucidated that that's the mechanism of increased hemoglobin production. However, it should be noted that excessive erythropoiesis is maladaptive. It can increase blood viscosity and lead to strokes and myocardial infarction. So pathology then, we've got pulmonary edema, acute mountain sickness, and cerebral edema. There's a diagram for one of my third-year essays on the right, which I summarize what I thought were to be important mechanisms in high-altitude cerebral edema. The treatment then for most of these conditions involves descent. If descent isn't possible, a Gamov bag can be useful. This can help boost a barometric pressure and therefore help increase oxygen delivery into the lungs. Dexamethasone, you might be familiar for its use in treating COVID, is a broad spectrum anti-inflammatory and can help reduce AMS symptoms. Acetazolamide, we've mentioned. Nifedipine is a calcium channel blocker, so inhibits vasoconstriction. Also, beta agonists, for the same reason they're useful in asthma, help widen the airways. Now, those are all pathologies experienced by sea level dwellers going up to altitude. There are, of course, chronic pathologies which affect populations that live their entire lives at altitude. For example, Shuvash polycythemia is endemic in the Russian Shuvash populations, caused by a genetic mutation leading to basically loss of function or reduced function of the VHL. VHL is von Hippel-Lindau factor. And remember from your HIF work that VHL helps promote the degradation of HIF. So without it or reduced activity of it, you have enhanced HIF activity, which increases pulmonary vasoconstriction in response to hypoxia. Monge's disease or chronic mountain sickness, again, is affecting high altitude residents, particularly those that have moved up more recently, at least recently in terms of evolutionary terms. For example, Andeans or the Han immigrants in the Himalayas, compared to populations that have lived there for much longer, for example, Tibetans or Ethiopians. These patients have loss of the ventilatory acclimatization. So compared to people without disease, they're hypoventilating. They have also excessive erythrocytosis, and hemoglobin levels can really be quite high, which can lead to right-sided heart failure and reduced exercise intolerance, problems with breathing and sleeping, and finger clubbing as well. Okay, so these are just a summary of those responses. Let's move on to our final section then, temperature. So these are questions on temperature that have come up in the past. The role of the hypothalamus is quite often something that comes up. So just as a reminder, humans are homeotherms, and we maintain our core body temperature between 36.1 and 37.8 degrees, or at least that's considered normal. And in order to maintain that, we've developed during evolution exquisitely sensitive mechanisms in order to maintain us within that region. And we have both peripheral and central receptors, which are sensing changes in either core or peripheral body temperature. They are sending these to the hypothalamus, particularly the preoptic area of the anterior hypothalamus. These are integrated there, and appropriate responses are mounted. And remember that body temperature follows a circadian rhythm. We're slightly cooler in the morning, and there's also a change in temperature associated with the phases of the menstrual cycle. And this is just to say at the end that core body temperature is most accurately measured in the esophagus, but this is not that feasible clinically. So rectal, tympanic, sublingual, etc., are all suitable measurements of core body temperature. So when we're going to think about the regulation of core body temperature, I want us to consider this system or this model of temperature. And this is that we have a core which has to be kept at a very specific temperature in order for our internal organs to work properly. This includes our abdomen, our abdominal viscera, our thorax, our heart, and then ultimately the brain and hypothalamus. And then we have this shell. So those are our limbs, and it's less important that they're kept at a specific 37 degrees, and they participate in thermoeffector responses, which help us either dissipate heat when we're too hot at our core, or help us conserve heat when our core temperature begins to drop. So peripheral and central chemoreceptors. So again, thinking about homeostasis, we need to detect our error signal, so changes in the core body temperature. How do we detect this? Well, we have thermoreceptors, which are expressed by our A delta or C fibers, both in the periphery, so subcutaneously. These sense changes in the environmental temperature, so to facilitate feed-forward responses. So if you walk outside and it's cold, you can initiate heat-conserving responses before your core body temperature even begins to drop. And centrally, these detect an error signal. So once your core body temperature actually begins to change, these can mount feedback responses. These located in the abdominal viscera or the vessels of the walls of the great vessels. And just as a bit of experimental evidence, this work was awarded a Nobel Prize in 2021. How do our A delta and C fibers actually respond to temperature at a molecular level? Well, we have these transient receptor potential channels, our TRP channels, which are basically temperature sensitive. So as temperature changes, there's a whole family of them. They have different thresholds for activation. Some are activated at heat, for example, the valenoid receptors, the ones with V's in them. Again, some very high temperatures, some at slightly lower temperatures. And then we have our menthol ones, the ones with M in, which are activated by mild cooling. And the activation of these leads to action potentials within these cells or depolarization, which can then be integrated centrally to mount compensatory responses. So just a reminder of this equation. So homeothermy, or basically the maintenance of the right cold body temperature, is achieved by balancing production with transfer to the environment. And production is basically our metabolic rate. And then we have ways that we can retain, or we can either gain heat from the environment or lose heat from the environment. That's radiation, convection, conduction. It's like GCSE physics all over again. And also evaporative heat loss. So basically heat loss due to sweat. And acutely and chronically, we can modify these terms to ensure that our core body temperature doesn't fluctuate too much. And the magnitude and direction of convection, radiation, and conduction will depend upon the temperature gradient between the shell, so our limbs, and the environment. And it's modified by vasomotor control, which essentially controls how much of the blood gets close to the environment. Remember the thermoneutral zone, that's the range of temperatures in which only vasomotor control is needed to maintain, in which our core body temperature is maintained by, let me start again, sorry. The thermoneutral zone is the range of environmental temperatures within which our core body temperature can be kept within that physiological range by only employing vasomotor responses. So basically vasodilation or vasoconstriction within our shell. Outside the thermoneutral zone, we need other responses, particularly behavioral responses, which are mounted predominantly by the hypothalamus. So this is just to show here. The thermoneutral zone is these range of ambient temperatures in which we can control our body temperature by just either vasoconstriction or vasodilation. So when there's a warm stimulus, when we're in our thermoneutral zone, so it gets slightly warmer, we can just vasodilate. This increases heat loss via our shell. Conversely, when there's a cold stimulus, we can vasoconstrict. And there's also the deep veins in our shell run adjacent to our arteries. So there's also a countercurrent heat transfer system. So heat from the arteries is transferred to the returning blood in the veins so that less is lost in the periphery. And obviously this is at the expense of our extremities getting cold. So that explains why things like our fingertips are particularly vulnerable in cold temperatures. So as I said, the hypothalamus is the major central integrator of inputs regarding temperature. There are thermoregulatory neurons in the preoptic anterior hypothalamus, which detect changes in the temperature in the body as a kind of error signal again and initiate counteracting thermoeffector responses. This is outside of the thermoneutral zone. The set point, basically the temperature at which the hypothalamus is happy and is not going to mount any either cooling or heating responses, can be changed in the context of infection, for example. And this is a host defense mechanism. So prostaglandins, for example, or inflammatory cytokines or bacterial pyrogens can all change the set point of the hypothalamus, which means that our body temperature increases, and this is a defense mechanism. It can be maladaptive, of course, but it can help us, the body, kill bacteria. Antipyretics, so things to reduce things to reduce body temperature, can basically antagonize the production of some of these mediators. So response to heat outside of the thermoneutral zone then. So sweat is an ultrafiltrate produced by the eccrine glands. As our production is increased, there's less time for the reabsorption of some of these electrolytes. So this can lead to excessive loss of important electrolytes. So we need to replenish these if we're sweating a lot. There's also acclimatization. So that's the kind of acute response outside the thermoneutral zone. Chronically then, We can increase our perspiratory capacity. For example, aldosterone can help promote sodium reabsorption, so we're not losing all that sodium. And this can happen within about 6 weeks of exposure to warmer climates. Response to cold then outside the thermoneutral zone. We need to minimize our radiation, conduction, and convection heat losses. One way we can do this is we can increase our basal heat production. For example, shivering will do this, exercising will do this. So exercise, as we said, we can increase our metabolic activity by nearly 20 times. So this is obviously going to lead to a lot of heat production. But this is important. It's important to note that if we're exercising a lot, this can increase peripheral blood flow. So this might be counterintuitive, because if we exercise, although this is going to generate heat, what it's also going to do is increase the blood flow to the periphery, and therefore losses to the atmosphere in the form of conduction, convection, radiation, etc. It's been increasingly recognized that brown fat metabolism, particularly in the neonates, is an important way to generate heat. So in brown fat compared to white fat or normal adipose tissue, mitochondrial metabolism is uncoupled from ATP synthesis, leading to lots of heat production. There's due to expression of something called the uncoupling protein, which essentially allows that proton gradient, which we'll remember from biochemistry, to be discharged without generating ATP. There's also hormonal ways to increase body temperature, for example, with the use of by the production of thyroxine from the thyroid, and this can increase basal metabolic rate by nearly 100%. And there's also other lipolytic or glycogenolytic hormones, for example, testosterone growth hormone. This is just a summary of the hypothalamic regulation. So remember, sensory inputs are integrated in the hypothalamus. The hypothalamus has a set point, the temperature at which it's happy, where it's not going to mount responses. And this set point can be changed by, for example, circadian rhythm. We know that we're cooler in the morning. Ovulation, we know that it gets slightly higher in the periovulatory periods, or pyrogens in the context of infection. And this leads then to responses, whether they be thermoeffector responses in the thermoneutral zone, or more severe responses outside the thermoneutral zone, behavioral, or, for example, exercise or shivering. So just to demonstrate the thermogenic capacity of the skeletal muscle system, this is a clinical caveat here. You can see that in malignant hypothermia, which is characterized by, or which is, sorry, it's caused by mutations in the ryanodine receptor. So remember, that's the sarcoplasmic reticulum's calcium release channel. When people with these mutations, when they're exposed to anesthetic gases or depolarizing muscle blocks, they can basically this leads to a lot of heat production by these muscles, and can lead to hypothermia, tachycardia, and if not controlled, it can lead to death, actually, due to the excessive degree of warming. And you can reverse this with a ryanodine receptor antagonist, as well as cooling down the patient. It's very rare, but about one case per 100,000 general anesthetics. I'm going to skip past this, but this is just about brown adipose tissue as a potential anti-obesity target. It's been discovered that brown adipose tissue is not exclusively present in babies, but there's also some evidence for it being present in adults, and maybe this can be activated by, for example, exposure to the cold, and maybe this could be a way to burn energy to help with weight loss, for example. So just then to think about when we don't regulate our temperature properly, we can enter into a state of hypothermia or hyperthermia. The presentations of hypothermia include before I say that, hypothermia is defined by a core body temperature of less than 34 degrees. It's particularly prevalent in people that are less able to control their body temperature. For example, neonates, which can't mount appropriate behavioral responses, or the elderly, where thermoregulation or perhaps social deprivation can predispose them to hypothermia. It presents itself with neurological manifestations such as memory loss or slurring of the speech. There's also cardiac manifestations, particularly slowing of the heart rate. And then as you get very cold, ventricular fibrillation, which can be fatal, or often is fatal. The more mild version is frostbite. So as I said, if we preventing heat going to our very extremities, they can freeze, and ice crystal formation can lead to cell death, and this can cause gangrene as it thawns, as the tissue thaws. And the core body temperature happens much faster in water, and this is, as you know, specific heat capacity. We're going to lose much more heat in water than we will in air. Hypothermia continued then, so a loss of vasomotor tone and sudden extremity flushing can lead to paradoxical undressing. So this is basically you're removing clothes in the context of hypothermia, which obviously doesn't make any sense. Terminal burrowing then, so due to hyperactivation of protective, probably very primitive brainstem responses, people start sort of digging around for shelter. But hypothermia is not always bad news. In the context of surgery, for example, so heart surgery, sometimes they want to cool the body temperature, because then when you cool down, the energy expenditure falls approximately 13% per degree of cooling. And this is cytoprotective and can help that reduce the damage to our cells. And for example, there's a study here, a case study from in the Lancet in 2000 of Anna Bagenholm, who suffered cardiopulmonary arrest, but actually recovered after falling in freezing water. And when she was recovered, her core body temperature was 13.7. But this shows you that actually lots of her organs and her brain, for example, was being protected by that drop in energy expenditure. And as I said, this can be useful in the context of surgery. So hypothermia then is a medical emergency that can lead to organ failure and death if not rectified. And it's characterized by an increase of body temperature, core body temperature of more than 2.5 degrees from the rest point, or more than 40 degrees. Causes infection, exertion, so exercise, or just being exposed to high ambient temperatures. It progresses from heat exhaustion, where it's characterized by fatigue, dizziness, fainting, hypotension due to excessive sweating, so loss of that circulating volume. And it can progress to heat stroke when thermoregulatory mechanisms completely fail. This leads to confusion initially, then loss of consciousness, and ultimately death. The treatment for this is cooling, and there's evidence that cool water as opposed to freezing water is better, because very cold water can lead to vasoconstriction or shivering, and therefore an inability to lose heat via the mechanisms we've discussed. Okay, so that's everything for today. I apologize for running a few minutes over. I'm happy to stay behind and answer any questions if you have any at this stage. Alternatively, my email is here on the slide. I'm happy to take any questions via email. Now, it would be absolutely fantastic if you could fill in the QR code, scan the QR code, which will take you to a feedback form, which if you fill in, you'll get a copy of the slides. And if you do that, you'll also get a copy of the questions I put at the end. So these are some multiple choice questions which I've taken from past papers, which you can work through. But yeah, if you could scan the QR code and fill in the feedback form, that would be fantastic. And thank you all very much for your attention on a Friday evening. I appreciate it's not the most social hour, but thank you nevertheless for coming along. And I wish you all the very best in your exams.
Thank you very much, Aaron.
Yep, I can post the link. Or perhaps I can't. Well, I can just write it out. If I stop share, actually, because I don't think we need the slides anymore, then I'll copy it. Okay, that should be the link for the form. So I've got a question on. So it's a good question actually. You've asked about the differences in the responses to sprinting and a long run versus incremental tests to exhaustion. So yeah, this is a common essay, and obviously the essay question, and obviously the responses that we mount are different. As I mentioned, there's changes in the factors that, or the responses that drive the changes in cardiovascular or respiratory performance. So in a sprint, obviously we're not having much time to generate those feedback signals. So probably a lot of it's feed forward. So I would talk a lot about the things that are driving the response. Obviously in long runs, you've got an accumulation of lactate, for example, which may be more important than a sprint. If you think about a 100-meter sprint, by the time you've built up any substantial level of lactate, you've already stopped exercising. Also as well, there's the fuel sources. So there's, as I mentioned on that slide, you see that in the early stages of exercise, so particularly relevant for the sprint, you've got breakdown of local sources of fuel. So ATP pools, myophosphorylase is mobilized, as well as glycogen stores are mobilized. Obviously, this is not sustainable. So in a longer run, you're going to move towards aerobic metabolism, breaking down initially glucose, then giving way to lipid metabolism. And the other thing I guess you can talk about as well is that isometric contraction versus dynamic exercise. There's differences in the ventilatory triggers in those two forms of exercise as well. Hopefully that's useful. Oh, and of course the anaerobic threshold as well. As you get moving towards exhaustion, you're going to go past that anaerobic threshold, and obviously we spoke about the implications of that on the ventilatory response as well. So that hopefully won't be reached if you're on a gentle long run. Yeah, I guess so. You've asked whether you can say a similar thing for incremental tests to exhaustion. Yeah, as I've said, as you hit that anaerobic threshold, that has implications for what's driving ventilation and cardiovascular performance. Obviously, it depends on the duration, how quickly you're exhausting, what fuel sources you'll be mobilizing. But yeah, in my experience, there's definitely been questions on comparing a sprint versus a longer run, for example.